So, hi everyone. My name is Ali Kassouf. I speak on behalf of the How I Treat COVID-19 team. So today's webinar is on the management of kidney cancer during the COVID-19 pandemic. We are honored today to have Dr. Anil Kapoor, medical oncologist, Mrs. Nancy Barnes, patient survivor, and Ms. Rina Calabrese, also a patient and survivor of kidney cancer under treatment right now. Boaz is our coordinator. Boaz did a great job coordinating everything and honestly setting up everyone. I need to special thank to Kidney Cancer Canada, to Kidney Cancer Research Network Canada, Quebec Cancer Coalition for all the work they're done and help, and the Association Pulmonaire Quebec Lung Association, who did a great job coordinating everyone and taking care of the sponsoring. The Lung Cancer Association is a member the Union for International Cancer Control, and they were actually the link between us and giving all our webinars an international exposure. So the outline for today is very straightforward, and honestly, it's a very casual meeting. We have a brief overview of the management of kidney cancer before COVID-19 and after COVID-19, and this is the second. It takes us to the second. So how did the pandemic influence the whole care? Testimony or intervention from our patients, and then a live Q&A. For our participants, there's a chat box on the top. I'll open it to you, and just feel free to have to ask any question during the webinar. We're going to take the questions as we go, and after that or afterwards, there will be a live Q&A that we will address Dr. Kapoor and I. Just zoom etiquette. So click on the chat for any questions. Just write them. We use the gallery view to see all the panelists, and for any other inquiry or follow-up or something that you remembered afterwards, do not hesitate to write to us on webinars@howitreatcovid19.com. The webinar is going to be recorded, and is already recorded, and is going to be available on YouTube on our channel. Boaz will issue a report afterwards, and of the main points that we will discuss today. These reports are going to be sent to the medical associations, where we will take them and to prepare on how are we going to manage if there will be a second wave, or how to take care of our patients on a larger scale. So without any, I'll hand over to Dr. Kapoor, who's going to start with the slides.
Thank you, Ali, for having me. I just have a few slides. I know we want to make it a interactive discussion, so look forward to any questions from the audience. You can either type them in, or if you want to unmute if you're allowed to unmute your chat, you can just speak to me as well and pipe in. Again, so we'd like to just have it more interactive rather than didactic. I am Anil Kapoor. I'm a uro-oncologist in Hamilton, where we have this Urological Cancer Center for Research and Innovation, which has been through the philanthropy of multiple patients, including some kidney cancer patients. We've been able to do some innovative work in kidney cancer research and other urological malignancies. So I encourage you to go to the website and check it out a little bit. And again, I'm going to talk a little bit about localized disease and metastatic disease. And because it's a lot of patients online, I'm going to start from first steps, just so we can understand kidney cancer a bit. I'm just going to minimize my pictures here. There we go. So kidney cancer in general has been increasing mainly due to detection bias. We're doing many more ultrasounds and finding these kidney tumors just by accident. And so I can't tell you how many patients we have who have really had an ultrasound done for gallbladder pain and found a tumor in the other kidney on the left side, or some other vague pains, and just incidentally found a growth in the kidney. And then we're able to cure it because we picked it up so early. So I think that most of the time localized disease, when it's I'm not sure if you can see my pointer, but non-metastatic disease is about 70 to 80% now. And regional disease is about 20%, where there's some local advanced disease. And metastatic disease is about 15% of patients now that present to our clinics.
We do see the pointer, by the way. We do see the pointer.
Oh, you do see the point. Oh, thank you. Thank you. So most of these are now found by accident, but sometimes you can have blood in the urine. And whenever anybody has blood in the urine, the message out there is see your doctor right away. Never ignore blood from any place that's coming from your body. Certainly from the urinary tract, we want to see right away to find out where that blood's coming from. and any unexpected weight loss or weakness really should be looked at by your doctor, and if it's blood in the urine, certainly by a urologist right away to have it checked out. And then often we do these ultrasounds or CT scans, and this is an example of a CAT scan where there's a growth in the kidney. And this little spot here, this could be just a cyst. It could be a tumor. It could be a benign growth of some sort, and that's where we often look into it further with further imaging, or I consider a biopsy. And this is a CAT scan, and this is a picture of a MRI as well of the same patient where you see this growth that doesn't look like a cyst. A cyst is a water-filled sac of fluid in the body, in the kidney, in the liver, and the ovary. And simple cysts or water-filled cysts of the body are never, almost never a cancer. We can never say 100%, but almost never a cancer. And solid growths of any part of your body does need to be looked into to find out why that growth is there, usually with a biopsy or excision. And so this is how we see most patients when you have blood in the urine, or if you just incidentally, you'll find a spot in the kidney or other parts, and then we look into it further. This is an example of a larger spot in the left kidney here, and the spot here in the kidney. And again, this is more of a solid picture rather than a cyst. Most of the time, these are just cysts, but these solid masses we find on CAT scans or MRI do need a workup to make sure that they're not cancerous. And that's usually with a biopsy or with just excision. And then once we find a spot, the first thing you have to do as a patient is have it staged. That means to see if it's gone anywhere else or how far it's gone in your body. So this staging, stage 1 is cancer less than 7 centimeters, like those pictures I've just showed you. Stage 2 is when the cancer is over 7 centimeters. Stage 3 is when the cancer is into the adrenal vein or into adjacent tissues, such as the vein. So this is stage 3 cancer. And stage 4 is when you have a metastatic disease. And when we can get these localized cancers, stage 1, 2, or 3, the cure rates are very high. You can see these numbers here on this slide, 95% for a tumor that's less than 7 centimeters, like those tumors I just showed you. The cure rate is exceedingly high. For stage 2, the cure rate can be also high as 90% for even larger tumors. And even tumors into the vein, the cure rate is up to 65% now. And so catching them early is always very good to help patients have their cancer cured. Once we stage it, we need to know what kind of cancer it is. And there's different types you may have heard about. Clear cell is the most common, then papillary type 1 and type 2, and then chromophobe renal cell carcinoma are these pathologies. And these are found by biopsy or excision of the mass. And so once you stage it and know that it's not spread anywhere, you want to get a pathology grading of what type of cancer it is and how aggressive it is. Most of them are clear cell, which is sort of middle of the road kidney cancer. Type 2 papillary is a more aggressive one. Type 1 papillary is least aggressive, and chromophobe is even less aggressive than the other ones. So these kind of pathologies are important to clarify. And these oncocytomas you may have heard about, or angiomyolipomas, these are benign growths that never spread and never metastasize. So then once you stage it, you want to grade it, and the grading tells you how aggressive the cells are inside. Grade 1 and grade 2 are less aggressive, and grade 3 and grade 4 are more aggressive. And this helps us. Once you get that information, during COVID, we can determine how aggressive to be with regards to the cancer management. For example, if somebody has a stage 1 cancer less than 7 centimeters, and it's grade 1 out of 4, this is very non-aggressive and can be watched even for many years sometimes. So there's no urgency to put the patient at risk for COVID if it's a grade 1 or grade 2 and a smaller size tumor. So the grading and the staging helps us decide how aggressive to be during COVID and even outside of COVID with regards to the cancer. And so for localized disease, like those pictures I showed you, the CAT scan, we now have this evolution of surgical techniques where back in the 70s when I was born, not really, we used to do a radical nephrectomy or partial nephrectomy in that days in the 80s. And then 90s, now we do keyhole surgery or belly button surgery, it's called. And now we can do partial nephrectomy. And now we're actually doing robotic surgery, which is really fantastic across the country. And this also helps with recovery and getting the cancer out appropriately. And what this stands for is single port surgery, where sometimes we're going in through the stomach, making a hole in the stomach and doing the surgery that way. That hasn't really taken off a lot, but it's an option for patients with smaller tumors. But in Canada, this hasn't taken off like it is in the States because it takes a bit longer and the benefit is less. Or say the benefit is not as good as with robotic surgery. And the way we do these radical nephrectomies with keyhole surgery, we just basically use these portholes and we take out the kidney tumor and pluck it out. And now we can do these robotically. And so we have very precise tools to excise the tumor and get patients with a faster recovery. And this also has implications during COVID because your hospital stay is less, sometimes just overnight, and your recovery is faster, so less risk of being exposed to the COVID environment. So now to the issue at hand is how do we triage during COVID? Again, we're now in the tail end of the first wave, but there's always a second wave they keep talking about in September and other waves. And always, I think we can have a discussion outside of this lecture, but I think that so this change is here to stay. We're always going to have some sort of distancing measure to manage our patients with cancer, localized and metastatic. And so I think we're always going to have some sort of distancing measure long-term now that we're in this new environment in the world. So a lot of it depends on the resources at your hospital. So for example, in Ontario, Toronto has a higher rate of COVID, whereas in Hamilton at my university, the rate of COVID was quite a bit lower. So we're able to do these surgeries and we had more availability of PPE. And so we're able to actually do the surgeries during the last few months, whereas in Toronto, they were shut down completely. And when I talked to my friends in Quebec, including Dr. Kassouf, one of my good friends at McGill, Ellie's good cousin, they were shut down in Montreal for quite some time for surgeries because of the high incidence of COVID. And so it was variable across the country based upon the availability of resources, PPE, and the incidence of COVID in that area. So in general, though, the recommendations I'm going to go through briefly are that lower grade cancers, like I just talked about, grade 1, grade 2, smaller tumors can be delayed significantly, and that way the patient's not at risk, certainly in high volume COVID areas, such as in the past, Toronto and Montreal. These are the general recommendations during COVID for surgery, is that those tumors that I talked about, T1, low grade, they can be delayed up to 6 months safely. We have lots of data to show that you can delay it up to 6 months with good safety and no compromise to the patient. And if it's beyond 3 months of a delay, all we have to do is just do another imaging, such as a CT ultrasound, to make sure the mass is not changing. So if your surgery is delayed because of COVID, whatever city you're on, maybe just talk to your doctor about getting another imaging to make sure that the mass is not changing while you wait for surgery. And most of the time it's stable. T2 tumors that are larger, shouldn't be delayed beyond 1 to 3 months is our recommendation. And T3, T4 tumors, that were the ones we talked about, stage 3, stage 4, they really shouldn't be delayed beyond 4 to 8 weeks and should be done more urgently because of the higher risk for spread. Now, those are guidelines from Canada. These are guidelines from actual published guidelines from the Europeans. And they actually mimic the guidelines I just gave you in that patients that have T1 tumors. So they use a little more jargon here than the jargon the lines I used on the last slide. But T1 tumors, less than 4 centimeters or less than 7 for T1B, they can be delayed up to 6 months safely with some interim imaging. And T2, we recommend, again, before 3 months, and 6 weeks for the T3, T4 tumors, which we put at 4 to 8 weeks to get done. And I think those are been validated around the world that this is the time frame for surgery. Now, if you're not having the surgery done at that time, and we had that experience here in our area as well, where in St. Catharines, Niagara was shut down because of COVID, there's an obligation, I think, to see what center can do your surgery more urgently. And so we did have some patients come in from Niagara Falls to do their surgery more urgently because of these advanced disease. And that's really just putting the patient first to get their cancer treated appropriately in a timely manner and safely. So that's all I'm going to say about surgery, and we can take some questions about that. Now, for advanced disease, usually that's medical management or chemotherapy, we talk it, or targeted therapy or immunotherapy. I used to use chemotherapy as a word that treats cancer. But right now in kidney cancer, we use what's called immunotherapy with ipilimumab, nivolumab, pembrolizumab. These are the drugs that are approved for advanced kidney cancer. And one of my colleagues, Dr. Lalani, one of our rising stars here in Hamilton, was able to get all the medical oncologists together to publish a paper prioritizing systemic therapies for malignancy during the pandemic. And he published this very quickly, early April. And this has been quoted actually around the world now as some guidance for our colleagues about how to manage advanced cancer with systemic therapy. We also have an organization called the Kidney Cancer Research Network of Canada. Dr. Hutt is one of our medical oncologists as well in Ontario and our Dervinsky Cancer Center. He was a lead author on this, which published at the end of last year about what we recommend as guidelines for treating kidney cancer in Canada. So this is really information for our medical oncology community in Canada, gives them some guidance. And I'll just translate this table for you. This is patients who have untreated kidney cancer or just present with metastatic cancer. We recommend now as a preferred treatment, if you have what's called favorable risk disease, axitinib and pembrolizumab, or if you have intermediate poor disease, ipilimumab with nivolumab, or axitinib with pembrolizumab. I know all these MABs and MIBs are very confusing, but these drugs basically are immuno-oncology drugs with what's called tyrosine kinase inhibitors, TKIs. And these targeted therapy with the immunotherapy have become the standard of care for untreated metastatic kidney cancer. And any new patient should be on one of these two regimes. If they have intermediate poor or favorable risk, should be this as a preferred option. And then the bottom of the table is if patients progress on these drugs, we recommend either cabozantinib or axitinib as options for the next line, which are oral pills, tyrosine kinase inhibitors. And in general, what we were trying to, during the peak of COVID, in high volume centers was, high infection centers, cities, was try and minimize the immuno-oncology drug because of the visits to the hospital, the risk of infection, and the overall gestalt that you want to try and minimize your visits to the hospital because of the risk of getting COVID if there was a high volume of COVID in that center. And so the recommendations from Dr. Lalani and the medical oncology community is that we really have to make sure that we, first of all, are fair and equitable and safe across the country to treat our patients, and everybody gets fair treatment for their disease. We have to triage it by priority levels, but everybody needs to be respected and treated as a priority. And we have to just have innovative ways to deliver therapy, minimize hospital visits, supportive measures to prevent admission. Sometimes immuno-oncology drugs may have less side effects, but when they do happen, they can be profound side effects. So we want to minimize hospital admission and exposure to COVID as well. So the thoughts were to have more oral medication, which may have less potent side effects as opposed to the immuno-oncology drugs. Understanding the immuno-oncology drug is really the standard of care now for metastatic kidney cancer, and trying to adjudicate that based upon the center, the city, and the instance of COVID that's there. So a careful balance is important, and again, communication with all the medical oncology colleagues across the country. So these are the recommendations for kidney cancer, is that if you can hold off, then maybe not do any therapy. And this is what's called active surveillance. And we just looked at our Canadian-wide experience that there are some patients where the kidney cancer is progressing so slowly, even with metastatic disease, you can actually just keep an eye on things. These are patients who may have some low volume or small lung spots that are not growing very quickly at all. And those patients, rather than put them at the risk for COVID by putting them on drug therapy, just keep an eye on them for a while. And that's as long as it's safe, and it can be safe in a number of patients. But if therapy is required, then maybe an oral pill, such as we just talked about, the cabozantinib, axitinib, may be an option for patients in first line. There's also pazopanib or sunitinib, which has been around for 10 years. Sutent and Votrient are very strong drugs to treat kidney cancer. And maybe for some patients, maybe an oral pill would be a minimum to start on, and add on the immunotherapy drug afterwards once the COVID incidence has decreased and the patient is not at risk for that. However, we have to weigh that against the standard of care, which is the immunotherapy with the pill. And again, pembrolizumab with axitinib or ipilimumab with nivolumab. These are standard of care drugs, and we have to balance that based upon how it is in that particular city with regards to treating it. Again, it's very important to get the immunotherapy, because with these drugs now, you can actually get up to 10% cure rates with ipilimumab and nivolumab. There's been a quoted 11% complete response rate, which is really a fantastic number, that 1 in 10 patients can have a complete response with this regime. And that's really unheard of over the last 20 years of my treating kidney cancer, and very exciting for patient response. And now once patients have progressed on second-line therapy, again, the standard is for kidney cancer is pills. And so that's actually very good that we can give them cabozantinib or axitinib as an outpatient to minimize their risk of complications, minimize their risk of admission to the hospital, minimize their hospital visits, and so on. So that's what we've been doing anyway, and that works out well for second-line therapy. This is a hot topic called cytoreductive nephrectomy. This is patients who present with kidney cancer and their kidney is still in and taking the kidney out. That is an option, but what we're recommending during COVID for cities that have a high incidence of COVID is that defer the nephrectomy, start on systemic therapy first with those drugs I just talked about, and then you can safely delay the nephrectomy depending on response and the COVID curves. So I think that's recommendations that everybody agrees upon across the country, and it's safe for all of our patients. So I'm going to finish off there. If you have any questions about systemic therapy, if you have any questions about localized disease, I'm happy to answer it. This is my Twitter handle if you want to get a hold of me. That's my email. I'm happy to take emails from patients as well, and communicate if I can help in any way. This is Niagara Falls. This is in the backyard of Hamilton, and that's I go swimming there all the time. So thank you very much for your time, and I'm happy to take any questions.
This was honestly great. It's crazy. Well, it's great overview of all the questions. I'll take the questions of some questions we've got in order. So, is immunotherapy being used as a preventive treatment for patients with no active cancers post-surgery? In other ways, is immunotherapy used as an adjuvant therapy for now?
That's a great question. So what happens is after I talk, those surgeries that I showed, maybe we'll go back to that. Are you still seeing my screen? I'm not sure if it's...
Yeah, we do, yeah.
Because I think the beginning are very important for patients to advocate for their own care. These 3 slides are very important. So if somebody has grade 3 or 4 cancer, as in this slide, or they have papillary type 2 or clear cell, or if they have stage 2 or 3 disease, the risk of the cancer coming back after surgery is higher. You can see the numbers here that are on this slide. Let me minimize this here. Are about 40%, right? 40% risk of reoccurrence of stage 3 cancer. So the standard of care right now and around the world is just to cross your fingers and hope you're in the 60%. And so the role for a drug after surgery is called adjuvant therapy, where somebody who has no disease after surgery, but knows that they're at high risk of a stage 3, for example, is to get a drug. And the drugs that were the pills called Sutent, Votrient, or sunitinib or pazopanib, sorafenib, these were all negative trials. They basically showed that unfortunately patients did not live longer or have a higher rate of the cancer not coming back if they went on those drugs. But we have some exciting times coming up where we have 3 trials that are closed with adjuvant ipilimumab, nivolumab, adjuvant pembrolizumab, and patients receive this for a year after surgery, and this may decrease the risk of the cancer coming back. Those trials will read out in the next few years, and they're very exciting. There's also a trial right now going on across all the major centers, including our center, where if somebody has their kidney cancer in place, you can get neoadjuvant nivolumab, or 1 dose of nivolumab before surgery, and then 9 doses after surgery. And it makes a good biological sense to prime the immune system that may decrease the risk of the cancer coming back as well for these high-risk tumors. And that's very exciting. And I think that my gut feeling is that adjuvant immunotherapy is going to be the way of the future, and that's going to be exciting for patients.
That's great. It takes me to a personal question. So we have one of the things that struggled during COVID is access to clinical research and drug development. This is a big deal in oncology, because every trial that is open and that is currently now recruiting, and then you get to stop it or to stop recruitment or amend the protocol or change everything, it can bias the result, or it can bias the the progression of the trials. For the last 3 months, everything had to be stopped. So what was your perspective out of this? First, would you consider trials that kept recruiting during COVID time still reliable as results, first? And second, if you can tell us about your experience in your center, did you continue doing the trials as before, or did you stop on specific trials?
Yeah, those are great questions. And I mean, clinical trials are always very important because of these novel new drugs that you have an opportunity to have. We've had some amazing results with the immunotherapy drugs, and it's been nice to offer those through clinical trials and compassionate use programs. For us, the trials were on hold in Hamilton, and that was disappointing because we had some advanced cancer patients that would have been, I think, would have been great for getting preoperative nivolumab and then afterwards. But I understand that these trials had to be closed or not closed, but put on hold because of the risk of COVID. We really didn't want a blow up of COVID based upon hospital visits and staging and so on. So I think that the government actually did a fairly good job to control COVID and reopening of the country. And I was disappointed the trial was on hold, but I would agree with it. It may affect the results to some degree, but I think it's the reality we live in, and we'll just have to compensate that when we do the final analysis. We're now reopening again, and we're able to recruit for these trials. So it was a 3-month hiatus. And so what I did in Hamilton is that those patients that I wanted to put in the trial but couldn't, I just took them straight to surgery, because even though our COVID rate was lower in Hamilton, the trials are still on hold as a policy decision across the province. And so I just took them to surgery as we should, putting the patient first to get that cancer out.
Mm. And some centers also, although it was a little bit not like some patients needed surgery, and some centers didn't have access to surgery, so they allowed themselves to treat patients systematically until surgeries or this operating rooms got available. How do you comment on this, knowing that neoadjuvant treatment is not actually the way to go in kidney cancer?
So, I mean, I think this pandemic hit everybody out of the blue, and everybody was just trying to do their best to take care of patients as best they could. My opinion is that if your surgery can't be done in that city or that center, then you should send it to a center or city that can. So in Ontario, we had some centers that had low volume of COVID, such as Hamilton, but although other cities also had a lower incidence of COVID. And for example, Niagara Falls had high incidence, Toronto had high incidence. I think that those patients, the oncologist or the surgeon should have a discussion with other cities to see, can we get the surgery done to optimize that patient's care? Maybe if that in some centers, if there's no option for that, then giving systemic therapy to temporize or treat that is not a wrong decision at all. And I think everyone's just trying to do their best to take care of patients during this horrific pandemic.
I'm getting a lot of questions. I'm going to ask them. I'm going to ask just one, and then we'll proceed to speak to our patients, and then afterwards we'll continue the other. But one is very important because it's so if you get a complete response on immunotherapy, and we have lots of patients that get complete response, or they get like at least a very stable disease for long. And as you mentioned, IV treatment can be we can stop it for a while and then continue it. And we know from many many practices, they doubled the dose of Pembro and made it every 6 weeks, knowing that also pembrolizumab axitinib was a protocol that was almost approved a couple of weeks or a couple of months before the COVID pandemic. So many centers didn't have experience using it, especially in community hospitals. So two questions. When would you feel withholding immunotherapy, in which response or at what time of the treatment would be risky for patients? So do you feel more safe having a complete response or having a stable disease on 1 or 2 scans until you stop it? And for Pembro axitinib, did you double the dose of Pembro and went through from the start with the dosing?
Mm-hmm. Well, those are great questions. And I guess what I would say is we have quite a bit of experience with Pembro at my center, because I was involved in what's called the CLEAR study, where patients were given lenvatinib with pembrolizumab, and we had a number of patients that I treated with that combination, actually about 15. And we've had some amazing responses on these combination therapies of complete responses, even after a few doses. For example, one patient of mine received the pembrolizumab with the lenvatinib through the clinical trial before COVID, but was still getting treated during COVID as well, but developed some cardiotoxicity where sometimes that drug can affect the function of the heart. So only received 3 doses. Unbelievably and happily, all the lung cancer went away, all the lymph nodes went away, and had a complete response, which was really exciting to see. And we stopped all the drugs, and the patient still has complete response 7 months later. So I think that you can stop these drugs if you have to. And there's a lot of research going on about stopping the drug and waiting for it to restart. Restarting the drug if you need to. So for example, part of the protocol for so many of these studies is that after you receive a finite doses of the immunotherapy, for example, you get 35 doses of pembrolizumab, then you stop the drug, and then you see what happens. And most patients can have a good, durable, long-term response, either partial response or complete response. And then once the cancer comes back, you can go back on the immunotherapy drug. So I think these are options for patients, and also you can extrapolate that during COVID as well. I think doubling the dose or doing it every 6 weeks, I think these are just ways to think outside the box. It makes biological sense you could do this by decreasing the frequency, and I don't think it's wrong at all, and it depends on the response of the patient. As long as they have stable disease or complete response disease, partial responses, these are all very reasonable choices to make.
And lastly, the follow-up of patients. We switched a lot, at least my center or anywhere else, to telemedicine and phone calls and everything. How safe would you feel from your perspective, before we hear the patient's perspective, to follow your patients on a phone call, knowing that they are on target therapies or immunotherapies, and many times we've missed side effects even with patients that are in front of us. And so how did you do that?
It was a worry. And again, I think these immuno-oncology drugs are amazing drugs. I mean, this was a Nobel Prize winning advance a few years ago. But when things go bad, they can go severely bad. And so the incidence of side effects are low, but when they happen, they're significant. Whereas with the tyrosine kinase inhibitors, these pills, Sutent, Votrient, Enlita, or Axitinib, cabozantinib or Cabometyx. The side effects can happen, such as hypertension or diarrhea, but they're manageable by just stopping the drug. Usually, you can get some. Very rarely, you get life-threatening side effects from the TKI class, where some of the side effects from this can be life-threatening with immunotherapy. So I worry about that, and I always tell the patients, if you have anything, you call me. In fact, I often get my cell phone number to patients on immunotherapy, which is really not a good idea all the time, I worry about the fact that if we're not seeing them in person, that things can happen that they may not realize. They have to get the blood work, absolutely, because you can get basically some immune infiltration of any organ, such as diarrhea from infiltration of the bowel, called colitis. You can get hepatitis, but liver function tests going up. You can get pneumonitis from lung inflammation, shortness of breath, also thyroid dysfunction. So you really need to keep an eye on patients and have them understand that these side effects can be significant, and to give us a call immediately. And the treatment is steroid therapy and not antibiotic therapy, and have that communication very, very close with your clinic nurse and yourself.
Perfect, thank you. I still have a lot of questions. We're gonna get back to that at the end. We're gonna see, hello, Ms. Calabrese, how are you?
Good, how are you?
Good, good. So I guess we're just gonna go through quickly what you, tell us your story, tell us what worried you, tell us what we did as a medical community. What did we do right? What did we do wrong? How can we find ways to improve in case anything happens again?
So for me, I'm undergoing treatment with immunotherapy. It's the nivolumab, and I go once a month to my hospital to get the IV treatment. And since the COVID-19, even though my hospital is actually in a hotspot, it's in Côte-de-Neige, which is a hotspot of Montreal, which itself is a hotspot. They have not stopped treatments in person. So I guess I'm fortunate that they're still doing the treatments there. But of course, they have put in place safety measures. So the big difference is when I go now is they have people at the entrance who will force you to put a face mask on. If you don't have one, you have to, of course, sanitize your hands, and they take your temperature. They ask you a bunch of questions. If you've been anywhere in contact with anyone who has COVID, if you've been tested, near anyone who's been tested, like all kinds of questions like that. And then once I go up to the floor where I do my treatment, I mean, of course, they disinfect the entire chair that I do my treatment in. And, you know, of course, the technician has a mask on as well. But I mean, other than that, it hasn't, I mean, my husband isn't able to come with me anymore. They don't allow any family members into the hospital, only the person who's having the treatment. And they've also blocked off chairs in the waiting room so that there's, you know, every second chair is blocked off so people can socially distance. But I mean, other than that, there hasn't been for me that much of a difference since the COVID-19, which I'm very happy because that was a concern for me that I wouldn't be able to have my treatments.
Did you feel they spoke to you about being immunocompromised and being worried about infections and everything? And this is something that Dr. Kapoor and I didn't address yet, is the risk of infections in patients with kidney cancer undergoing treatments. Here I believe from a medical perspective, we need to differentiate for the sake of all the attendees, patients that have that just got surgeries and don't have any signs of treatment of disease, active disease, which was one of the questions that was sent to me. So these patients should not have an increased risk of to be immunocompromised. It means if you got surgery and you don't have active disease.
Well, I do though. I do. I have a tumor in my spine still.
No, I mean, I'm opening just a brackets just to simplify one thing. I'll get back. So for patients like you, being on active treatments and having different tumors, yes, the risk of immunocompromise, you still are considered having a little bit of immunosuppression. However, being on immunotherapy under the studies that were done during COVID, we didn't see an increase in the risk of infections from COVID for patients with undergoing immunotherapy.
Right, and I actually asked my oncologist that question because the drug is supposed to boost your immune system. So I asked him, like, does that make me safer and less at risk of getting COVID-19? And he said there hasn't really been any studies to show that, so he couldn't really answer the question.
Yeah.
But I mean, theoretically, it makes sense, but I don't know if that's the case or not.
Yeah, well, the immunotherapy is increased T lymphocytes, which are lymphocytes that are memory cells that we would want them to attack the cancer. However, we didn't see an increase in the risk or a decrease in the risk of complications from COVID-19 based on small specific series. We're going to see in the future, but of course, this doesn't apply to someone who has an active cancer with metastasis and then went and had a lot of complications. That would be a completely different subject. So one of the main questions I will address it to you. So patients undergoing immunotherapy, as Dr. Kapoor mentioned, they do very well, and these are very good drugs. However, they can be side effects can be slowly happening. How were your side effects managed, and did you feel that a questionnaire over the phone was enough to make you feel very well followed?
Yeah, sure. I mean, I haven't had a lot of side effects. I mean, it has affected my thyroid gland, so I am taking medication to control that. And I've had a couple of occasions where I felt slightly nauseous, but other than that, I mean, I haven't really had any side effects, so I guess I've been very fortunate. I've been tolerating it very well.
And were you still seeing your physicians during your visits to the hospitals?
Yeah, my oncologist is still continuing to see his patients in person.
Okay, and did you have CT scans, blood tests? Where were they done?
I'm actually going this coming week to do a CT scan, and then the following week for an MRI.
Did you CT scan during the treatment?
Yeah, I had them done. Well, it was early though, like in March. But okay. Yeah, they did. You know, again, they made me wear the mask and disinfected everything. So.
Right. And if anything, because one of the things that we as medical community are still discussing as well, so in case this happens again, do we need to shift the patient's treatments to an outside clinic of the hospital, because this was mentioned in many institutions, and this was done in some institutions where patients, instead of going to the hospitals, they go to private clinics where they get their infusions on different centers. Would you feel that it would be a good idea, or would you prefer staying at the hospital and getting your treatments in the hospital?
I mean, personally, I don't mind going to the hospital. I don't feel like it's too risky. I mean, they're pretty good about keeping everyone safe. So I do feel like it's okay. But I mean, yeah, there will probably be less of a risk going to a private clinic, because I used to go to a private clinic in the first year of my treatment. And of course, it was, there was only 2 patients. The most they could accommodate was 2 patients at a time. So of course, there's less risk. Whereas at the hospital, you're in a large floor with 20 other patients. So.
I have other questions regarding just your social life, and how did you manage this during the COVID time? And where did you get your information from? What sources did you go to get the information, whether on the pandemic or on your cancer care?
So for the pandemic, well, to answer your first question, the way I've been dealing with this pandemic is I haven't been leaving the house very much at all, because I am concerned about it. I don't want to get sick, because I don't know if I'm more compromised than normal people. So I haven't really been leaving the house that much. I've been socially distancing, not, visiting my family, just staying home with my husband, and being very careful. And in terms of where I'm getting my information for the pandemic, I've been reading the newspapers, the Globe and Mail, the Montreal Gazette, and then also going on the Quebec government website to see what their regulations are. And then what was your other question? Oh, for the hospital. Yeah, for the hospital, I mean, I've just been talking to my oncologist when I go see him, pretty much.
Resources for cancer care, because we've done a lot of initiatives were done, and also a lot of collaborations were done during COVID time. And if we're going to go to create new resources for patients, what were your resources? Social media, news, medical associations, patient support?
News mostly for
News.
me.
Okay.
Yeah. But to be honest, I was a bit surprised that the hospital didn't reach out to me to, give me any information.
Mm.
You
You didn't get any like pamphlets or any brochures from the hospital describing?
nothing.
Okay. And would you feel like, going back now, thinking about it, would you feel that it would have been a good idea for your physician to send you to address these issues in a specific way to you? Or would you feel this would be the pharma, the industry that provide the medication that should get you this, or the patient support groups, or where would you be most safe getting these information?
I would have liked to have gotten something from my doctor, something from my oncologist to reassure me of what they're doing, the measures that they're putting in place to protect the patients, and whether it's safe for me to continue going to the hospital to do my treatments. And they never really provided me with that kind of information, that reassurance.
Excellent. Okay, perfect. Thank you so much. Really, thank you. And good luck for your next. Thank you. Ms. Barnes, how are you?
I'm good, thank you.
Good. Go through. You have tell us your story. How was everything? How was the pandemic? How was life now happening afterwards?
Well, I consider the pandemic still on. I'm still kind of living under the same umbrella as I have for the last few months with COVID, because it's not gone. And I figure if I get it, there's still a risk. So as long as there's a risk, I'm going to be maintaining my same behaviors. I'm on an oral targeted therapy called cabozantinib, which Dr. Kapoor discussed, and that's my 3rd line of treatment for metastatic renal cancer. And so it's just in pill form. Actually, I'm just going to be switching treatments shortly. But so I've only been in to see my doctor once since the pandemic has started. And then I have since had a CAT scan, and I actually even had my results over the phone with a discussion with my doctor. And I really like that.
Oh yeah, did you feel safer just not going to the hospital or because of the pandemic, or did you feel that even outside the pandemic, if getting the information over the phone would be enough for a patient on cancer therapy?
Well, for me personally, going into the cancer center has a lot of triggers, you know, like getting in your car, driving 30 minutes, parking, getting into the building, waiting. It's all very anxiety producing anyways, even before COVID. And so to eliminate that and just have a direct phone call, I found when the few times I've had phone calls with physicians over the phone, I find it less distracting in a lot of ways. I can be in my own comfortable environment. I'm not all distracted and stimulated by everything else going on around me. And I feel more focused, and I find the conversation has been somewhat better even. So dealing, you know, having those conversations that way.
Yeah, because this is something very important for us also, as we're like, once you're there, there's no way back, because like people like telemedicine now. They like, not exactly for the reason that you mentioned. However, as I addressed this question, Dr. Kapoor, did we feel safe? No, on our ending, we were worried. And Anil, if you have any way you can also address it as well. We were worried about some side effects and some missing out stuff. I mean, if there's a lump that just appeared and I used to examine it and know that it happened there, I would have known at an earlier stage that some cancer is relapsing or happening. And this is a little bit, so I mean, shifting between some visits and some follow-ups at the same time, as you mentioned, giving you, I believe was a good result over the phone didn't seem as a bad idea. But for us, calling to give a bad result over the phone is very uncomfortable from a medical point of view. I know what was your experience?
No, I agree. Yeah. So I actually, if it's good news, I'll give it over the phone. If it's bad news, I won't do that. I usually, so we were still seeing patients in our clinic during COVID again because the incidence was lower. So I also would feel terrible giving bad news over the phone, and so I bring them in person so that we can, with the family member. And also you have to remember, sometimes on the phone it's just one person unless you're on speakerphone. So giving bad news to without the other family member listening is always very tough. So I agree. And also, you know, I think patients like the telemedicine thing, and it's great as well for me as well to do the telemedicine, but it's hard to know what can go wrong. That's the problem, right? So it's hard to know what can go wrong when you're just on a phone call or a video conference. And the blood work, sometimes patients are less apt to do the blood work because they say, okay, well, if it's just a phone call, probably nothing too serious going on. Whereas in person, you can review the file, review the blood work. We're more attentive as doctors if we have you in front of us, where we can look at your CAT scan pictures, we can look at your blood work in person to discuss it, look at your body and any rash, how you're feeling, how much weight you've lost, how you look. It's hard to do that in telemedicine or even by telephone, because you can't adjudicate those kind of things. A lot of it's a gestalt about the overall how you're feeling, rather than and the change that we look at from what you were before. So I don't think it's the best care, but it certainly is convenient.
Yeah.
I prefer seeing my doctor in person.
Yeah, so
more reassuring.
Yeah, this was very important to mention, because patients on oral therapy compared to patients on IV therapy, the approach was completely different. One of the things also, especially that you are on cabozantinib, so the management of side effects, one of the things also, especially at the start of therapies, I believe you were already on the treatment and it was not started during the COVID time. Would you believe that a pre-written questionnaire that would be developed, sent to you and written, and then having it sent to clinician would be a good way to follow up, or just a conversation over the phone, going through some questions would be enough? In other words, I mean, do you believe documentation of everything from your side or from our side would make you feel a little bit safer, or would be not necessary?
You're asking me?
Mrs. Barnes.
Oh.
Yeah.
Okay, I need a little bit of a clarification, I'm sorry, of that question.
So I mean, we because we are along with some medical associations and medical support groups and patient support groups, we are looking at ways to keep track of side effects, because this is one of the major things that worry us. So one of the things is, yes, we rely on a phone call, which takes 3 or 4 or 10 minutes sometimes, and we ask you some questions, but during that phone call, maybe you forgot what you wanted to ask us or anything. So documenting or sending questionnaires in advance, or anything in advance, would you feel this would be an added benefit, or is there any other way that you'd feel safer in us following you as a patient?
I think that that would be a very good idea, because then you're not on the spot and you're able to reflect and take a little bit of time to fill that questionnaire in. And during my phone call, I think they were, I don't know, I don't usually get, well, because I didn't speak to the nurse before I spoke, I just spoke directly with the doctor. So there wasn't really, we went straight to the results. So there wasn't even really a discussion on the effect of the side effects.
Hmm. What was one thing that you wish happened during the COVID? This would be a question also for both of you, and it did not. And you would wish that, oh, I wish my doctor would have done this, or I wish my hospital would have done this to make you feel safer during the times of.
I would have liked, Rina Calabrese said, I would love to have maybe had COVID directly addressed to me. I got my information, same thing, from the media. I have friends who are nurses and, you know, did some of my own research, but in general, I didn't have any health professionals at the cancer center anyways, directly discuss COVID with me and, you know, the implications for my care or the risks that I might be at.
And Rina?
Same for me, yeah. I was a little surprised that nobody reached out to me.
And would you feel that medical associations or like Canadian Urology associations or experts like Dr. Kapoor or documents that come from patient support groups as well would be also helpful, or a platform that would be helpful for you as a patient, or even sent, or you would prefer to be sent directly from your physician? Do you find it the same?
I think absolutely that would be very helpful, for sure. Yeah.
Yeah.
That's great. One of the last questions I will address, and I believe it's good to be mentioned for everyone. So, if someone got COVID, what would be afterwards? What's next? And from medical perspective, patients that had COVID in the past and that need to start their treatment in the next treatment, there's no evidence that there's an increase in the risk of reactivation or an increased risk of getting COVID again, or an increased risk of having more complications. So if someone got COVID in the past and they tested positive and they went through and then they got diagnosed afterwards of cancer, there's no evidence to the increase of any side effects or anything. Adding to that, in kidney cancer, one of the good things that's happening is treatments are not kind of chemotherapy as in terms of chemotherapy, so they do not affect directly the immune system. So we're talking about immunotherapy and targeted therapies. And up until now, based on many documentations and articles that were presented and published, there's no evidence linking targeted therapies, hormonal therapies, or immunotherapy drugs to an increased risk of dying from COVID for patients having cancer. There is a direct effect from having COVID-19 and having advanced stage cancer, older age, male compared to female patients not having the progressive disease during this, but there's no direct correlation with these specific therapies.
But I did hear about people having issues with their kidneys when they have COVID-19, and I do only have one kidney, so that is a concern as well.
Me too.
Yeah, no, that's true. There is a possibility of affecting renal function, so that's a concern with only one kidney, because a lot of patients after having their kidney out, their renal function is still pretty good, but not perfect. So that, I agree, that's a concern.
One of the last questions also to have is what are the precautions that you are taking at your center, and what to expect, because we don't know what to expect in September, and I believe now we are in the curve of catching up with delays in surgeries, delays in biopsies. We had a lot of delays in biopsies. So all our patients, I had at least 5 or 6 patients from March to June with this definitely stage 4 kidney cancer, but we couldn't have access to any biopsy during that time. So now we are trying to catch up in terms of treatments and therapies. What are the measures that you are taking care now other than that?
Well, so what's interesting that's happened is because for 3 months, doctors were not seeing patients in general for new problems, we're now having a surge in new diagnoses. So what that means is the patients that had blood in the urine, they weren't, their ultrasounds were all canceled. Patients who were not seeing their doctor, patients who had pains in their abdomen were not seeing their doctor. All the ultrasounds, all the imaging was canceled. So what's happening even in the last 2 weeks for me is that we're now doing more endoscopies and more ultrasounds, and we're having a surge and new diagnosis of kidney cancer and bladder cancer and prostate cancer, because all these tests are now being done, diagnosing patients that were on hold for 3 months. So how we're going to deal with that is that we're talking about doing overtime. So we're talking about doing evening ORs, weekend ORs to catch up on this. And I think that there is going to be a problem with delayed diagnosis for new patients that were not picked up from those 3 months. I think things were completely on hold. All the CAT scans were canceled, and these were called elective CAT scans, right? Patients, if somebody's bleeding actively, for sure you can go to the emerge and we would do an emerging CAT scan. But if somebody has a little bit of blood in the urine or has a abdominal pain, all those elective tests were all canceled and now being rebooked. And now we're picking up all these new things, and there is going to be a big surge in new diagnoses that need to be treated. And so how we're going to be able to deal with that capacity, it's going to be a problem over the summer. And then we have the second surge in September. That's also going to be another issue about how to get these treatments done for patients. So it's going to be a tough problem. And I also see, even now looking at the hallways of the hospital that I'm still at tonight, is it's much more hustle and bustle. You see a lot more people in the hospital, a lot of people still wearing their masks, but many people are having lunch not wearing their mask, I noticed. So I think it's going to be interesting to see how that all develops. The beaches in Ontario have been packed over the weekend, like in Quebec. So we'll see what happens with all that as well.
Yeah, that's totally true. So one of the things that we had in different other specialties as well, patients are scared now even to go to the hospitals for screening for breast cancer, for breast mammography, ultrasound, for example, or so. So we will see how coming to the hospital, we didn't see an increase in patients coming to our clinics during these times, but we are trying to catch up what we had in the past. So yes.
Well, the hospitals have, there's an Ontario-wide hospital network. And some of the administrators at the government level that are involved in health in Ontario have said that we're not going to get back to normal for 4 years.
Oh my gosh.
So that was a scary number, I thought, but you know, I'm just a worker. So you know, we're just trying to do our best for the day-to-day patient and get them through and get them taken care of as best we can.
So I honestly, thank you all so much. This has been a great webinar. We've done at least 9 so far. I believe Boaz agreed that it's great. Thank you all so much.
Is this the best one, or?
It's definitely the best by far.
Okay, good. That's all Nancy and Rina and I wanted to hear.
So thank you all. There's going to be a report issued. It's going to be available on the internet. We're going to send it also, and it's going to be recorded as well. So if you have any other question as well, please do not hesitate to send it to us at webinars@howitreatcovid19.com. The platform is going to be up and running. We're going to do a lot of activities as well in collaboration with all the patient support groups and other experts and collaborators. So please don't hesitate to contact us. Dr. Abu, thank you so much again. It was great. Nancy, Rina, good luck. And thank you again so much for everything.
Well, thank you for the work you're doing too. It's good.
Yeah, Ellie, great job on this, and Boaz, great job.
Thank you.
Thank you.
Have a great time. Have a
Everyone
great
take care.
Bye bye.
Bye, everyone.
Thanks. Bye-bye.